his presentation, with a short Q&A session afterwards, and then we will have Ms. Jennifer Nicholas share her presentation with another Q&A portion. And be sure to stay until the very end of our meeting for any important announcements and for the checkout QR code. And so to welcome our first speaker of the night, Dr. Nick Ellis, who is actually the founder of the MedLife organization. We are extremely lucky to be able to have him come and share his wisdom with us as both our organization's founder and as a surgeon. Dr. Ellis founded MedLife in 2004 after being inspired by his experience working at hospitals and as a translator for a medical missions organization in Ecuador. And he received his MD and completed his emergency medicine residency from Dartmouth Medical School. And currently he works at MedLife International and at the ER. And MedLife is a nonprofit organization which works to raise awareness about global health and development issues and gather donations for low-income communities and also host volunteering events. So now I will give the floor to Dr. Ellis.
Great, thank you so much. All right, guys. Well, I think we have a pretty quick agenda, so let's jump right into things. How many of you had a chance to watch Bending the Arc? Did everybody, or did kind of half of you, just to give me a sense of where folks are at? Maybe could you raise your hand if you did have a chance to see it? It'll just help in conversation. Okay, maybe most folks know. Okay, great. So, and I think most people are in pre-med. So let me ask you a few questions, and my hope is that we can do this a little bit as like a chalk talk. That is my preference, rather than just sort of talking at you. I would hope that we can kind of just have more of a conversation and kind of move the needle a little bit. So my question for you, and then I'll just kind of give you my background real quick, is what makes healthcare successful? So how do we decide when healthcare is successful? And if you could just jot down your things, and I'll tell you a little bit about my history to give you a second to jot that down, and then we'll chat. So my background, I went to McGill University. I studied international development. Yeah, healthcare in general. Yep. However you'd like to define that. If you're going to PA school, if you're going to nursing, if you're doing biomedical engineering, however you'd like to define it, what makes it successful? So I studied international development at McGill University in Montreal. Through that, spent some time in Panama and Ecuador. It was really in my last year in Ecuador. I was shadowing at a clinic, and I did some work at a public health NGO that studied the effects of the rose industry on indigenous health. And it was really through those two experiences, working at the clinic and that NGO, that I decided that I wanted to go to med school. So I was not pre-med. Decided in my last year that I would go to medical school, so had to go back, do a kind of quote post-bac. I didn't really do a formal post-bac. I just went to my local state school and did all of my pre-med classes. And then you heard I went to med school at Dartmouth, did emergency medicine, finished that, and in 2016 moved to Peru. So I live in Lima, Peru, where I work with MedLife on a daily basis. And over the last 7 or 8 years, I fly up to Houston, Texas once a month, and I do all of my ER shifts in one trip, and then I come back. That changed slightly. I have 2 little boys, and so in December of this year, I went to every other month. And so that's the kind of condensed version of my life. I'm happy to get into any details with you guys, but first, I'd love to hear from you to talk a little bit about healthcare and MedLife and how we decide if we're successful in this work. So can I hear from a couple people? What do you think makes healthcare successful? How do you define success in healthcare? Anybody?
And people in the chat are saying that, when all ailments can be treated and are treated, when access is made available to everyone, decreased readmissions, when healthcare professionals can work together to address the needs of a patient, whether that is by building their trust, making healthcare accessible, diagnosing them, or treating them, identifying and solving healthcare issues in the community when there's a positive outcome, when patients are treated.
Cool. Great. Those are some great thoughts, guys. So a lot of them kind of focusing around, I mean, it seems like decreased admissions. So let's like talk about that. So decreased admissions, really what you're talking about is like effective care, right? Care that worked for somebody and they didn't have to go back to the hospital, right? A bunch of folks said when access is made to everybody, right? And so that sounds like you think that universal healthcare at some level is how we define success in healthcare. When you can identify and solve healthcare issues, so kind of solving those problems at a community level when there is justice. Great. So let me ask you the next question. So how many of those things apply to the American healthcare system? Do they all? Do some of them? Sad face. Thumbs up with the sad face. Lots of community and collaborative effort. So Renat, what do you mean by that? Is that a success or a failure? Community and collaborative effort. I know it's nerve-wracking to speak in front of a large group of people. Cool, John, can you talk about that? What do you mean by that? There's a failure in equal healthcare resources. What does that mean?
Sure. I mean, I used to work as an EMT, so, and one thing I noticed that is when I worked for like the government squads, they were less staffed and they had perhaps like less equipment and less ambulances compared to transport squads. And even the transport squads, which are, they sign contracts with hospitals, and they usually have very robust, they're very well equipped, and they're easy to work for. And unfortunately, the 911 emergency squads don't have the same resources all the time. So I think that's one of the examples that I've noticed where there's a failure in equal healthcare resources.
Cool. Yeah, Nisha, can you talk about that? Failure in accessibility to healthcare?
Yeah. So I live in like a very rural, like at home I live in like a very rural area. And a lot of the problems in the community come from like the fact that doctors don't want, there's not a lot of doctors to treat the patients. There's a huge patient population because it's like a retirement community. So we have like a huge elderly population, which is already like a marginalized group, but then you add on to the fact that it's a rural area, so a lot of the doctors don't want to come there because they'd rather be in like a city or somewhere else. So then you have this large population that's just not being treated, and then that's happening like all over the country, where there's like a disproportion of like urban centers versus like rural areas where there's just not enough doctors in those areas to treat the patients.
Yep. So it sounds like, as a theme, guys, would we say that it's fair to say we think that equal access to resources makes healthcare successful, effective treatment so that we're not getting bounce backs makes healthcare successful, but it really sounds like a theme of equal access to resources and treatment is a big thing for us. Is that fair? Yeah? Thumbs up? Yep. Okay. Next question, and again, I'll talk a little bit about some of my experiences while you write this down. What makes healthcare successful in developing countries? So when we think about organizations like MedLife, what makes healthcare successful? What are terms? What are ideas that come to mind to decide if something is successful, right? So while you jot those thoughts down, I'll just tell you kind of basically, people often ask how I started MedLife and why, and I'll tell you that story while you think about that question, okay? So when I was working with MedLife, I had graduated, I had done some of my pre-med work. I was working in a hospital in rural Ecuador, and I was recruited by a medical mission organization. So I was working with an orthopedic surgeon, helping them in the OR, and really just being sort of like an intern in a hospital. I got recruited by a medical mission organization because I spoke Spanish and I had some understandings of the healthcare system. And it was through that experience working with this medical mission that I was really exposed to people volunteering in sort of a MedLife style trip. And really, my experience wasn't all that positive. And so kind of what I saw was physicians like myself going down to a developing country and really handing out a lot of medicines, maybe some amoxicillin, some Tylenol. But if anything really complicated happened, like a little child came in and needed heart surgery, or God forbid you diagnose somebody with cancer, there was really no plan in place. And so there was no real ability to treat anybody with any complex disease. And that, to me, didn't make a lot of sense, right? Like, if people are going to volunteer and fly to another country and put all this energy into providing free care, it really didn't make sense to me that once you find somebody that's really sick, you would just sort of put your hands up and say, well, I'm sorry, we don't have the ability to treat that. And that really set me on the course that over the next 20 years has become MedLife, where I said there's got to be a more effective way to do this. And so really we set out not fully knowing how to make it more effective, but committed to the idea that we could make it more effective. And what that's evolved into is always partnering with local physicians, always partnering with local nurses, partnering with the local infrastructure. And so now our mission is very much to try and find the sickest person, right? And so whenever I'm on a mobile clinic, I'll frequently say to community leaders, who's the sickest person? Was there anybody that was so sick that they couldn't walk to the clinic today? Take me to that person, right? And we're trying to find the sickest person so that we can help them work through the healthcare system. How does MedLife do that? Essentially, let's say a kid has a need for a heart surgery. A doctor may hear a heart murmur at one of our pop-up clinics. We send a nurse to their house. We do an evaluation. We try and understand some of the resources that the family has. We then figure out which system they have to go into. So very much like in the United States, where we have Medicaid, Medicare, VA services, private, Peru has a similar sort of structure. It's fairly different in terms of how they actually implement that. In our hospitals, it doesn't, if I'm your physician, it doesn't really matter if you have Medicare, Medicaid, private care, I take care of you. In Peru, there's an entire hospital system just for Medicare. So if you have Medicare, you go to a totally different hospital than you do if you have Medicaid, and a totally different, so it's sort of like the VA system in the United States. And essentially, it's a really complex system that have lots of gaps in care. And what MedLife really does is help patients bridge those gaps. So if we diagnose a kid with a heart murmur and it turns out that that child needs heart surgery, then what we do is we work with the cardiothoracic surgeon, the pediatric cardiologist, to really provide the care that child needs over whatever period of time they need treatment. And so we've had some people that have worked with us for literally 5 or 6 years because they've had very complex medical issues. And there's other people that maybe it's a couple of months and they get treatment and they're done with the MedLife clinic. So that's basically how MedLife started. All right, so let's get back to the question at hand. What makes healthcare in developing countries like the work that MedLife does successful? Building trust with the community. That I couldn't love that answer more. What else? Consistency. Being able to treat curable diseases. Good. So Vish is throwing out trying to work within systems rather than creating parallel systems of care. Yeah, cool. So what about sustainability? Is sustainability important? What do you think? Yes?
I would
Top
think so.
1, 2. Yeah, go ahead,
Yeah.
please talk about that. Why is sustainability important?
I was gonna say that it was like a system of care that's being established within another country by another country. It should be like a system of care that can at least like be developed on and like last. So not only is that sort of like turn into like a long-term solution, but it could also turn into like a system of care that can also add like preventative like methods and tools to it.
Yeah, Donald, I love that. Yeah, building on top of systems that are already in place. Yeah, that's great. It's a little bit like Vish was saying too. Other thoughts, guys? Okay, so I think from my perspective, you know, the thing that I hear about and that I studied very much so was sustainability. I don't know if you had a chance to watch this movie, Bending the Arc. If you didn't, I'll give you a quick summary. So, Bending the Arc is a movie about Dr. Paul Farmer. He was an infectious disease doctor. Oh, got somebody in class again. So Bending the Arc is about this physician, Dr. Paul Farmer in Boston, and an organization that he built that worked in Haiti and a lot of other countries. And one of the big themes coming out of Bending the Arc was, and the reason I'm talking about this is that Vish and I are in Peru. I came with Partners Health to Lima, Peru, where they had an MDR-TB project. So how many of you understand what MDR-TB is? Hands up. Yes. So MDR-TB is multi-drug resistant TB. So normal TB, tuberculosis, is treated over the course of about 9 months. Multi-drug resistant TB is a kind of TB that's been treated once over 9 months and then failed treatment and then has to go into a more complicated treatment, which takes like 2 years. And so part of what that movie was about was in Lima, Peru, back in the 80s, 90s, early 2000s, people would get treatment for MDR-TB, or excuse me, TB, and they might fail. So a small portion of the people that got treatment for TB would fail, and then they would develop multi-drug resistant TB. And so at that time, when Partners in Health was working, and that was really before I first came to Lima, Peru, if you had multi-drug resistant TB, what do you think at that time, say in the early mid-90s, was the treatment for multi-drug resistant TB? Does anybody know or remember from the movie? So it was effectively, there was no treatment. And so you really just went back in, maybe you got another 9 months of the same medicines, but frankly, you kind of passed away. And so part of what that movie is about is that there was this really big, huge public health problem, which is multi-drug resistant TB. Yeah, I don't know that it wasn't it illegal to treat. I don't know that it was illegal to treat MDR-TB, but it wasn't established. There wasn't an established protocol on how to do it, to answer your question. And so basically in the kind of work that we do, often the questions we'll get is this work sustainable, right? And so I think that's one of the biggest questions we get in developing country work, right? It's not something that as a physician in the United States, I hear a lot from people, but in the developing world, it's definitely something that we talk about and there's a lot of discussion around. What essentially happened was they took this really complicated disease, MDR-TB, and they said, listen, there's no way to treat this now. Let's get a huge grant. So essentially, Bill and Melinda Gates gave like $44 million to figure out how to treat multi-drug resistant TB. And then they treated multi-drug resistant TB in Peru. They proved that it could be effective. They created a national program, and then that national program went international. Okay. So the summary of the movie, or this part of it, right, is effectively they took something that was not sustainable in healthcare and they made it sustainable over the course of 20 or 30 years. Is anybody familiar with any other infectious disease stuff that could be parallel with that, with the American government going on right now? Does anybody know what PEPFAR is? So PEPFAR is a program that was created by George Bush, or approved by George Bush, to treat HIV. And it's been a wildly successful program. And the reason I bring that up is when the Democrats and Republicans just recently had a problem with the budget that didn't go through, is my understanding. But effectively, that again took a disease that there was no sustainable treatment, right? Something like HIV, right? Way back in the 80s. And it made it sustainable over time, right? And so part of what my hope was, if you had a chance to watch that movie, and if you're doing this kind of work, is really that one of the most important things I think is people that want to go into healthcare is the ethics of healthcare, right? And that's something that we didn't really talk about or didn't come up as success in healthcare, right? We talked about the correct diagnosis, right? We talked about bounce backs. We talked about universal healthcare. I guess we did talk a little bit about the ethics of it, right? In terms of the universal healthcare. But what are the ethics of how we provide the care that we provide, right? Are we doing a good job with that? Are we just worried about the correct diagnosis? And I think that in my work, and unfortunately, we don't have a ton of time to go into all those different things, but in my work, sometimes what I've learned over 20 years is that the work that you do may not be sustainable to start, but it is ethical. And if you start on the ethical path, you can work towards sustainability over time. And I think that that was one of the big messages that I was hoping you guys would pull out of this movie. If you hadn't had a chance to watch Bending the Arc, please, it's a great movie. Mountains Beyond Mountains is the same story. But that's one of the big themes to me. Young people will often say to me, I don't know how to start in global health. It seems like an overwhelming problem. There's so many places that need help. And I think the most simple message is start with the right thing. Start with the ethical thing. Don't worry about the sustainability of it now. Always keep the sustainability in mind in the long term. But sustainability is not something that you're going to necessarily find in the first part of your career if you go into global health. So, all right, guys. Well, we don't have a ton of time, so yeah. Netflix. Yep. I'm happy to answer any questions because I think we don't have a ton of time, and I'd really like to make sure that I answer anything that's kind of relevant to you guys. What questions do you have about what we've talked about so far, or how MedLife approaches some of this work, or maybe the movie? Anybody?
One question I had was, how were you able to balance like traveling abroad to help others while studying, or like how do you balance it right now while you're working as well?
Yeah, there's a lot of talk in med school about balance and kind of physician mental health. I will tell you, med school is not the most balanced time in your life. Neither is residency, And I think one thing that I've learned over time is balance doesn't necessarily have to come in the form of every day having balance, right? In a great scenario, it does. In a great scenario, you get 8 hours of sleep and you work out every day and you have a good meal every day. But I think all of you know that when final exams are on, sometimes you don't have the most balance, right? And you have to kind of be able to flex and expand your ability to deal with stress, really. And I think that that's the biggest thing, is understanding that if you're not balanced at a time or for a time, it's okay. Don't let that in itself beat you up, and try and deal with stress in a healthy way. So for me, doing some cardiovascular exercise, it's very easy, especially if you're going into healthcare. You'll hear a lot about drugs and alcohol, physicians not really doing the best with their mental health. And of course, that is not the best. So, understanding that balance is going to come in waves and seasons, and it's okay if you're out of balance for a little while, but always trying to work back towards getting 8 hours of sleep, working out, eating a good meal, stuff like that. What else?
Do you mind talking about, I know you're talking about a little bit before, do you mind talking about a little bit of that like challenge you had with balancing, ethics and the sustainability aspect of it, and kind of like how that
Sure.
looked like for the first start of MedLife?
Yeah. So again, in developing countries, sustainability is really a big thing. People will want to talk about that a lot. So we've had a number of kids, for example, that have heart conditions and have needed open heart surgery. We've had a number of kids. We had a kid that had, full-blown cancer. We've had all kinds of really complicated things, right? In my line of study, when we studied international development, the boiled down version was, if you had $1 million, probably the most effective use of that $1 million was to vaccinate a bunch of kids, right? Rather than, for example, get one kid heart surgery, right? Or if you could build 100 wells and bring clean water to 100 villages, that would be a more effective or sustainable solution than getting one child heart surgery, right? And so as I came into working in Latin America, I was really confronted with this idea, right? So we would meet a child that needed heart surgery, and I had been taught that if you have $1,000 or 10,000 or 500,000, whatever amount of money, the best use of that money was the use that got the most number of people the care that they needed. And yet, as I went through med school in the United States, what I started to see was that was not necessarily the case, right? We never turned away a child in the United States that needed heart surgery. I never told someone's parent who was going to go into the ICU and spend $500,000 over the next 2 months because they were going to be intubated and getting intensive care for 2 months that we shouldn't do that because we needed to fix the water system in somebody's hometown, right? And so I was really confronted with this idea that in developing countries, we were being pushed to say, what is the most sustainable? What is the quote most effective? And in the United States, the care was all about taking care of an individual patient, right? And I started to have to ask myself, why is it that in the United States, we're pushed to take care of individual patients, and in developing countries, we're pushed to take care of populations, right? And is it the right thing to say to a child, I'm sorry, we're not going to provide you the care you need because I'm going to provide vaccinations to a whole lot of other children? And it didn't feel like to me that was right, right? It felt like to me, if the treatment for a kid is heart surgery in the United States, then it should be the same thing in rural Peru, right? And I think, unfortunately, that's not really the standard in a lot of global health. And so that's really something that MedLife has worked very hard at. Is that kind of what you were driving at, Vish?
Yes, yeah, I think that really like hit on it perfectly. Thank you.
What other
I think
questions do
Gary
you guys
also had a
have?
question in the chat about basically how the healthcare landscape has changed over time and like in relation to the social determinants of healthcare.
In relation to the?
Sorry, social determinants of health. I think that's what you meant by SDOH.
Okay. How does the healthcare landscape change? Oh, goodness. I mean, I don't know, to be honest, that in respect to the social determinants of health, that I would say the healthcare landscape has really changed very much in the last 20 years in my eyes. So I think that the need for the healthcare system and providers to really understand, so a little bit, what does that mean, the social determinants of health? So the picture that you see behind me is Pamplona Alta. That is maybe a mile as the bird flies from my house. It's a large informal human settlement that is a shanty town. People don't have water. They don't have sewage services. There's no ambulances. There's no police force. Healthcare is virtually non-existent. It's really, really challenging. And that's about a mile from my home where I'm talking to you from now. The extent to which a lack of water, sewage, healthcare, education, a safe home influence health couldn't be more overstated. I mean, they are synonymous, right? And in the United States, for example, we don't have, as an emergency room physician, it's one of the most challenging things. I mean, I'll tell you a quick story. I had a young woman who developed an aortic dissection in her 30s when she was delivering a child. And because of her poverty and the lack of insurance she had, she lost the child to Child Protective Services because she couldn't manage her diseases and manage her children at the same time, right? So you think about that. I mean, that reality in Texas is the reality in this community that we're talking about, right? Is somebody is so poor and has such a lack of resources that they have this devastating disease, and the system's response to this devastating disease is, we have to take your children away because you're too sick to raise your children, right? It's not, let's make sure you have health insurance and all the resources you need to raise the kids and take care of it, right? So Unfortunately, I would say I haven't seen a real significant change in terms of that landscape. I think more and more there are conversations like this one that young people are having, and so I'm certainly hopeful that it will change. But I think that there's a lot of work to be had in that specific area. What are the worst and the best parts of my job? So in terms of my job, right, I work really hard at taking away people's pain and suffering. That is my job, right? So when people are afraid and they are suffering and they have a loved one who maybe is passing away, my entire job is to try and make that situation better, right? That to me is an incredible job, right? Like, it's an incredible privilege to be able to work to take care of people when they really truly need help, and be able to provide a living to my family doing that, right? That to me is what being a physician is, and is definitely the best part of my job. The worst part of my job is working nights and the administrative aspects of healthcare, which is very challenging. So, you know, we're trained to be physicians. We're not always trained kind of to deal with the administrative aspects of things, and trying to provide really great care and deal with the administrative aspects at the same time is fairly challenging. So I would say that would be the toughest part of my job. Was somebody going to have a question there?
Yeah, I have a question.
Yeah.
What public health and administration issues do you think we should be more aware of as we go more and more into healthcare?
Public health issues. I mean, that is a really broad question. I mean, so I think that there's a lot of different aspects of healthcare. You know, in terms of public health, I mean, things like what we talked about earlier, drug resistance to antibiotics is an incredibly big issue. I think that the thing that I would say over 20 some years of doing work like this would be, you know, when you go to med school, they'll tell you, if you listen to patients very carefully, they will tell you the diagnosis. And what that means is, if you listen to their complaints and their symptoms, they kind of present and they tell you what their symptoms are, right? It just makes sense. I think that that's also the case for public health, right? I think we as providers need to get better at really listening carefully to the public and to patients, and really understanding what issues they're going through. You know, all of us, essentially by virtue of the fact that you're at Johns Hopkins, you may have come from a place of not having privilege, but you are now on a trajectory of having privilege, right? By definition of where you are in life now, right? And as you go, I don't know that there's a ton of effort to connect you to people that don't have that privilege, right? More and more you get pulled off into a section of society that you're thinking about the diagnosis and this and that and the administration, and really taking the time to listen to people's and how they're struggling. That's what I would encourage you to do, is really learn how to build consensus, listen to people, build teams, learn about effective management and leadership. Those are the things that I've had to learn over time that I think are really important. Hopefully that answered your question, John.
Yeah. Hello. I have a question. How do you see MedLife growing, like, in the next few years? Like, what are some goals you or the organization has, like, in order to take the next step?
Yeah. So I think that one of the things that I believe about healthcare and developing kind of countries' healthcare, the kind of work that MedLife does, the model of charity is effectively broken. I think, you know, the idea that charitable organizations kind of do work, you know, as much work as they can with as little money as they can, I think that idea is a broken idea. You know, the idea that you're supposed to take on some of the world's greatest challenges with the smallest budgets, you know what I mean? I mean, if you said to Google or Apple, hey, try and tackle poverty with, you know, $5 million a year, they'd be like, yeah, you know what I mean? It just, you know, and so there's a bad understanding about kind of what charitable work is and the kind of work that we do. And I'm very much interested in trying to explore how charitable organizations can structure themselves like for-profit organizations to be more effective is one of the things that I'm interested in. And so, for example, there's a chain of schools here in Peru that's owned by a bank. It is a relatively cost-effective but high-quality solution for a lot of middle-class people in Peru. But it's owned by a bank, right? And so what is the bank's ultimate goal? The bank's ultimate goal is to be able to make a profit, right? They have investors, and like that's their mandate, is to be able to make a profit. I think that, you know, you think about an organization like Johns Hopkins or Harvard or Dartmouth, you know, these are nonprofits that function in a for-profit model, right? So everybody pays a whole bunch of money to go to Johns Hopkins, right? You take loans, and you know, there's all sorts of resources that any one individual is paying to make the nonprofit of Johns Hopkins effective, right? You all pay a whole bunch of money. I think that that's the kind of model that I think we need to apply to developing countries too. So whether that's healthcare or education, if we could use more of sort of a Johns Hopkins style model where we function like a for-profit, but ultimately that profit is used for nonprofit causes, I think that's a much more effective model. So hopefully that answered your question. There are more specifics.
So like finding ways to fund more. Is that what you're trying to say? Like finding funds?
Yeah. So like, for example, right, you guys may go on a MedLife SLT, right? You pay a fee to go do a volunteering thing, right? That's a way that MedLife can take in resources and use those resources to bring products to or services to low-income people, right? For example, Tom's Shoes, right? Tom's Shoes, you buy a pair of shoes, and so a pair of shoes goes to a kid in Haiti, for example. Patagonia, right? The owner of Patagonia built this amazing company and then just donated it to his nonprofit. So now every time you buy a Patagonia coat, some portion of those profits are going to go back towards nonprofits that serve the environment, right? So more and more, we're seeing this trend of sort of social entrepreneurship from especially for-profit organizations. Apple is trying to go green, right? So you're seeing that move more and more. I think nonprofits need to follow that trend as well, right? And so to be able to sell products and services that ultimately people want, that provide the services to people that we serve, if that makes sense. Another example, Danny, could be, for example, a private school like Hopkins living in informal settlement like this, right? So like if people could pay, you know, $50 a month to go, which would be pretty reasonable in a community like this, and I could get Hopkins to say, hey, all of you guys, would you be willing to sponsor 10 children at this school, right? That would be a way that people are paying for a service there locally. And then let's say you guys sell whatever, I'm just going to make things up, sandwiches, right? And through that sale, right, we're able to provide a bunch of kids school. Like if we could think about better and more creative ways to provide care, which is a terrible example. For example, maybe something more relevant to this class, like tutoring for organic chemistry, right? A bunch of you guys might say, hey, I'd be interested in tutoring for organic chemistry. We could make those profits then go to kids in Pamplona and Alta. That's the kind of thing that I'm interested in.
Oh, yeah, okay. Thank you. Yeah, I understand now.
Okay, we're kind of running over time here, so that will just be our last question. But thank you so much, Dr. Ellis, for your very insightful presentation. I love how interactive it was, and I learned a lot about healthcare accessibility, and I'm sure all of our members did. So yeah, thank you for taking the time out of your day to come speak to us. We truly appreciate it.
Absolutely, guys. Yeah, happy to help and happy to come back anytime. Thank you for having me.
So now we're going to move on to our next speaker, Dr. Ellis, if you want to stay on, or if you need to leave, that's totally fine. Our next speaker is Miss Jennifer Nicholas. I noticed that she's already, oh yeah, I see her. Hi, Miss Nicholas. I'm just going to like give a brief introduction before we have you present. Sorry, let me share screen again. Okay, so thank you again, Ms. Nicholas, for participating in our event tonight. Ms. Nicholas is the president of Johns Hopkins Bayview Medical Center and has been working with Johns Hopkins Medicine for 25 years, and she earned her Bachelor's of Science in Business and Management from Hopkins and a Master of Science in Real Estate. Ms. Nicholas completed the Learning Transformation for Value-Based Healthcare Executive Program through Hopkins School of Public Health and is a Carol Emmett Fellow. And she has been involved in many of Hopkins Medicine's strategic planning and manages the expansion of affiliated regional hospitals and organizations. And her roles within the Hopkins community are several. So now I'll hand it off to Ms. Nicholas to tell us about her amazing career journey. Thank you.
Thank you. Thanks for the lovely introduction. Can everybody hear me okay? Sometimes my sound goes in and out. So I'm just going to do a little bit of talking. I am not nearly as cool as Dr. Ellis, but I will say what it was interesting as I was listening to his presentation and some of the information he was sharing with all of you. I actually, so I have 4 sons, I'll just put that out there now. And when my second son was in high school, he'd asked to go on one of the kind of medical mission trips, a service learning trip. And we actually went with Hands Across America down to Peru. We were in Lima and Cusco. And so I will say I am non-medical, right? I am not a physician. I'm not a nurse. Please don't come to me if you're ever in a serious situation where, I need to intervene to help you with your life. But I am really good at administrating. And so my job was as a non-medical volunteer. And I will say that even though I didn't get to, kind of physically interact with patients and take care of them clinically, I think the experience for me personally was just as enriching. My son initially thought that he wanted to go into orthopedic medicine. And so one of the things that you will learn from my story is that we are not a family of medicine or healthcare. I will talk to you about how I stumbled into that. But my son ultimately chose a biology degree in college, but now works for DePuy Synthes, and he's an orthopedic trauma rep. And so you never know where your journey will take you. And so, for me, I thought I would start out by just saying, how I got into medicine. It was purely by chance. So all of you who are clearly decided in kind of the major direction in your life, as you can see from my undergrad, I went to Hopkins. I'm a Blue Jay, but I did my studies in the Carey Business School because I wanted to do international business, and really just started out my career going to school and working part-time because after I graduated from high school, I actually got married and started my family. I know it's shocking, but a very different kind of chain of events for my life personally. And so I decided that my husband and I at the time, we were 18 and 19 years old. I was still going to go to college. And so I went to night school and I worked during the day. And so again, I always thought I was going to go into business. I started working at Hopkins in facilities. My dad was an architect and realized very quickly that Hopkins was a fantastic place. I really didn't have any exposure to medicine, but I loved the environment, right? So Hopkins, as you all know, is an environment that's just enriched for innovation and just incredible talent. It's a place where you can quickly immerse yourself and find your people who are equally as excited about areas that you are. And so I found that pretty quickly at Hopkins. And realized that what started out as a job ultimately kind of became a career for me. And then, as you can see from my master's, I didn't think I was going to stay in medicine, even though I loved working at Hopkins. So I got a master's in real estate. And of course, I graduated from my master's in real estate in 2008 when we had the subprime mortgage crisis and there were no jobs in real estate. And so I decided I was going to stay at Hopkins. At that point, I'd really been in just kind of management and finance roles. Again, I'm a business and finance major, right? I can organize things. I was very much on that administrative side that Dr. Ellis said he doesn't actually prefer. That's the place where I love to live. I like complexity. I like to organize things. I like to make life easier for the docs. I really enjoyed working with faculty and along the way fell in love with academic medicine. And I will say that, you know, I've worked at Hopkins for long enough where, you know, there are these moments that are just so memorable in my career where working in pulmonary and critical care medicine with the cystic fibrosis team, right? I think you all know much more about biology than I do, but, you know, cystic fibrosis is that rare genetic disease where you get kind of thick and sticky mucus because of how the salt channels open and close. And I was there at the time when the team was doing the clinical trials to study ivacaftor, tricaftor. And if you know what those drugs are, they are actually near cures to cystic fibrosis. So what was previously a death sentence has now drugs that ultimately halt the progression of the disease and change the trajectory of these patients' lives. Many of them didn't get out of their childhood. Now they are all getting married and having children. And I was there when the lead researcher came into my office with tears in his eyes and said, we've done it, right? We finally have the results back. We have found this cure and a near cure. And was there when we had Nobel Prize winners awarded, right? Like these moments where you just say, this is incredible, right? This is what I want to be a part of. And you know, tried to find my way. And that was, again, as a non-clinician in medicine, right? It's, do I go into pop health? Do I want to do quality and safety? Do I stay in administration? I was working on the School of Medicine side, and then ultimately got the opportunity to join the executive team as chief of staff to the dean and CEO, and was honestly quite terrified to take on this job. But it gave me a front row seat to the highest level of decision-making and strategy and crisis management and, you know, internal, external communication and politics of an organization. And so I realized then that, you know, that I was really aspiring to have a bigger and bigger impact in medicine based on what I was exposed to. You know, this is when you get into like boards and rooms that I never thought that I would be sitting in, and had the opportunity then to take on from that position a health system role where I was in charge of strategy and partnerships with other hospitals and health systems. And then I spent a lot of time going down to all children's. We have a children's hospital as part of Johns Hopkins Health System, and that's in St. Pete's, Florida. And so spent a year going down there helping them with regulatory work and their heart institute. And during COVID, I know that was one of the questions. During COVID, I got to stand up the field hospital at the Baltimore City Convention Center and operate that for several months. I have to say it was a once in a lifetime opportunity. If you ever have the chance to do something crazy like that and you're not sure if you can do it, just say yes. The team was phenomenal. And I learned how you can build scaffolding for long-term sustainable infrastructure for things like population health through the pandemic, which I think we learned a lot from. And then from that job, I guess I must have just done a good enough job all along, and they decided to tap me for the interim presidency over at Bayview. And the reason I said yes to Bayview is because it's my why I'm in healthcare. It's because I realized that I could have an even bigger impact on the lives of the people in Baltimore and in this community. So if you are not familiar with Bayview, Bayview Medical Center is the 5th longest running healthcare institution in the United States. So that hospital has roots that date back to 1773. It started as an almshouse for the sick and the poor. And over 250 years, the Bayview has doubled down on that mission. It was an almshouse. It was a city hospital for a very long time. And about 40 years ago, it came into the Hopkins family. And so, you know, when I was listening to Dr. Ellis and some of the questions that you were asking, you know, about those social determinants of health, I will tell you that in Southeast Baltimore, we have one of the highest areas of deprivation indexes. And if that's not something you're familiar with, it's a measure of socioeconomic disadvantage in a neighborhood that is very specifically tied to health outcomes. We have incredibly medically and socially complex patients that we take care of out of the Bayview Hospital. And so for me, having the opportunity to work at a hospital like that has such a longstanding mission and commitment to the community, but that also is part of Johns Hopkins and that has that academic mission. It's just incredible. So we sit on, believe it or not, 130 acres in the middle of Baltimore City. We have green grass and beautiful flowers and landscaping, but we share the campus with the NIH. The drug addiction and aging services for the Hopkins system are out of the Bayview campus. We have a lot of surgical specialties like bariatrics and total joints, and oh my gosh, we do neurosurgery. We also have lung cancer, and yep, the R56. Yep, we can talk about that. So I think you know, there's a lot that happens on the Bayview campus to really impact the local community. One of the reasons that we partnered with Yards 56 specifically was because, so this is where I'm going to get it, wear my finance hat for a minute as a hospital president. So there are core community services that typically don't generate a hospital margin, right? Those are things like pediatrics, labor and delivery services, psychiatry services, right? The general medicine services that typically you're not the high end, you know, kind of glamorous surgical volume or cancer services, high end cardiac. And so when several years ago, it wasn't my decision, but I support the decision. The decision was to partner with BMS Baltimore Medical Systems, which is a federally qualified health center, because as such, that designation garners them the ability to receive supplemental resources from the federal government to support core community services like pediatrics, like labor and delivery, OBGYN services went over there. And so again, continuing to make sure that we were able to provide those services to the community is why we partnered with them. So there are a lot of hospitals in the state of Maryland and across the country that have closed some of those services because they're not financially viable. And I think that's, again, one of the reasons I'm really proud to work at Hopkins is because when I signed on to the presidency, a big part of it was understanding that we would continue to provide those services to this community. Because if we aren't there, I'm not sure who else would be. And so for me personally, I think it's a great source of pride to be able to say that, to work for an institution like Hopkins. One of the other things that I am super proud about, and Jacqueline asked me to talk about a little bit, is that not just professionally have I been able to thrive at Hopkins, and I think just through one, having privilege and opportunity, having mentors and sponsors at the right time, but also kind of raising my hand and just putting in the work, right? I could never have predicted that I would be a hospital president when I started out, but just putting in the work, but also raising a family alongside that. I have 4 sons. My oldest son is 28. I have a 26-year-old, a 21-year-old, and a 19-year-old. And I'm really proud of the fact that I was able to raise a family. I was able to be there for them as they were growing up. I was able to really live my values, right? And so that's one thing I will say too, is just, be authentic to who you are. You will find your people along the way. There is no single path. You just have to kind of carve it out as you go. And I was able to find people who understood that, that my family values were equally as important as my career, and they supported that. And, I think somebody asked Dr. Ellis about balance and, how do you find that balance? And I always advise people that I prefer saying that we all have to make choices, right? Because to find that balance, it requires you to make choices and to understand your priorities and to say, what's the higher priority for me today? Is it spending time, with my partner, or is it going to get the workout at the gym, or is it going to, to study? Or for me, it's, doing all the email that I have to at the end of a long day. And so it is about choice, but it is rooted in your values, and what ultimately brings you that sense of personal balance and well-being. So, Jacqueline, what else do you want me to cover?
If you could talk about how the specific relations between Bayview and maybe the underprivileged communities of Baltimore, or if you guys have any programs that do community outreach, that would be great.
Absolutely. So I'll talk about the programs and then I'll talk about the outreach. So, we are, again, as I said, in many other states, Bayview would likely be designated as a safety net hospital, meaning that we provide services to individuals who are either uninsured or underinsured or socioeconomically disadvantaged. And so a couple of things. So some of the programs that we offer are a lot for aging. The geriatric population in this country is growing significantly, and so we are an age-friendly campus, which means that we are geared towards optimizing surgeries for geriatric patients. We have a geri trauma service where we have specific protocols for how we take care of the elderly population and aging population. Bayview is also known for its addiction treatment services. So individuals experiencing addiction across a wide range of addictions. So psychiatry has a really large presence on our campus, anywhere from, very young to elderly, on an inpatient and outpatient basis. We also have a lot of behavioral health and mental health services. So we, as a hospital, someone asked about also how we track those kind of social determinants of health and create access for patients. We are required by EMTALA to see every patient that comes through the emergency department. And it's widely known in the community that Bayview will provide care to those patients. We are in a zip code where we have a pretty high number of patients who are non-English speaking, many of whom are undocumented, and they have nowhere else to go other than into our emergency room. And so we provide a significant amount of charity care to those individuals and have specific programs for them, like the Access Program, or thankfully, we just had legislation this past year. It's the Healthy Babies Act, where it now provides insurance coverage for prenatal services and delivery of individuals who do not have insurance because of immigration status. All the babies are covered once they are born because they're U.S. citizens, but in many cases, the moms are not. We also do a lot around trauma-informed care. We're a level 2 trauma center for the state, and we're the state's only adult burn center. And so, approaching the Southeast Baltimore community and understanding, as Dr. Ellis said, kind of the unique environment in which they grow up and the unique challenges that they face, and how we prevent re-traumatizing them as part of the healthcare delivery system, I think is really important. Some of the programs that we have on campus, so Panagis Galiasatos is a pulmonologist at Bayview who leads Medicine for the Greater Good, and that is an outreach program where he takes a lot of learners out into the community and on different in kind of education experiences. Sometimes they are providing direct patient care. I think it's he will be featured in the Hopkins magazine. I think it's this fall issue. So if you can pick up that magazine, or you want to Google Medicine for the Greater Good, you'll see some of the work that he does. And I think that as undergraduates, I know Panagis, and he loves working with anyone who is interested in doing more in the community. As a hospital president, it's a big part of my job to be visible, not just within the hospital, but external to the hospital. And so, for example, we spent a lot of time building pipelines in the surrounding high schools. Downtown, it's Dunbar. Over at Bayview, it's with Patterson High. And, we have very specific programs to invite students in to, want to become not just physicians and nurses, but also with our engineering students. And we need clinical engineers to help us fix all the equipment in the hospital, or, pharmaceutical techs who want to work in pharmacy. And so lots of outreach to be able to provide jobs to those individuals. I will say one of the other things that we've done, just because we know it's been a barrier to entry for a lot of folks, not just folks in Maryland, but across the country, is we're no longer screening for marijuana when you do your drug screening to become employed. I think as the laws are changing at the state levels, it's something that we found where, it has been a barrier for individuals, who use cannabis previously. And so those laws are changing very quietly behind the scenes. And it's not something that we have publicized, but in terms of providing access, I think it's important. When I started, the last thing I'll mention, really, and how we kind of reach the community is, again, we have a lot of Spanish speaking individuals around the community. And I was noticing that our employee base was not reflecting that community. And so we have recently started ESOL classes and are offering translation services through groups like our human resources team. We think a lot about that clinically, and how we are able to bring in translation services for patients who are non-English speaking. But when it comes to hiring a diverse workforce, you also need to think about that as well. So that was a long-winded answer to that question.
Thank you. That was very interesting. I didn't know that law passed. It's very interesting and new to hear about the ins and outs of hospital administration. And it's also very unique that Bayview has that program with the high school nearby. I know when in my area, our hospitals usually don't like to accept high school volunteers. So it's really cool that you guys do that.
We have a lot of learners on Bayview's campus.
If you don't have anything else that you need to add to or want to say for your presentation, we could move on to the Q&A part, so people can ask questions and you can answer them. So if anyone wants to put it into the chat, or they could privately message me, or they could just unmute, that would be great.
And I will say, so one of the questions I think that you had asked me, Jacqueline, was thinking about what do the hospitals of the future look like? Kind of what are the future trends? And so, I think for me, it's a couple of things, right? I mean, we are in this incredible kind of golden age of technology and data. And while it feels like it is so deeply ingrained in other parts of our lives, it's really not in healthcare. Or, we are digitally enabled, but we are not connected. Our systems don't talk to each other. Oftentimes, we are not using data in predictive ways to be able to. So, you know, I asked my team, you would think that I could be able to predict for you on any given day what the surge might be in my emergency department based on historic seasonal trends, or how I might need to staff up or down. We do not do that well, I think, as healthcare or as a healthcare system. I'd love to have all my patients wearing bio buttons. I'd love to have them all kind of monitored ambiently so that we can track the changes in their disease progression, so that things like hand hygiene, you know, these are things that are just, you know, safety metrics that we track as part of the hospital. I'd love for those to be done by bots instead of people. I want to see more remote monitoring. I want to see more hospital at home. There's a lot that we can do in people's homes that we do not need to do in hospitals. And I think that we have really robust home care programs now and the technology that can enable us to do that even better and to still deliver high quality care to patients. And then I will say, you know, I want to be technologically enabled, so that the people that work at the hospital can provide the empathy and the compassion and the love that our patients need, to help them heal.
I have a question, if you don't mind.
Sure.
So, considering your background in like administration and within the healthcare system, I wanted to see if you had any input about whether or not it would be practical for a physician to open their own practice in like current economic climate.
Yeah, so it's a great question. Yes, so I think that there are a couple of different phenotypes of physicians that I've seen, right? And part of that, I think, is the journey that you will all have to take, is if you do become physicians or whatever part of medicine you pursue, right? That's just one path, that I think you figure out what your phenotype is. So if you really want to, right, like me, I'm highly independent. I like to be in charge. I would want to own my own business, right? I'm relatively entrepreneurial. I would say, yes, you have the ability to still do that and to do it successfully. So take the time to learn about the business of medicine, right? Or partner with somebody who knows it well. The other piece of this is there's a lot of private equity out there right now. And so if you build something, right? So the notion of, you know, if you're in business, the whole idea is you build a company, or even with startups, you know, biotech startups, you build a company, you sell it. And that happens a lot in medicine right now. Private equity is buying up different sectors of medicine. And so they will bring in some of the operators to help you kind of run your own practice. So that's kind of like on the like ultra uber business side of it. If you are just interested in academic medicine and you want to do research and teach folks, right, go work in a place that really values that and protects your time to be able to do that. That's what we do at Hopkins, right? We say clinically, you're going to work 2 days a week. The other 3 days a week, you get to do whatever you want in your lab, or you can teach. All of those models exist and more. And so I think, right, I mean, you know, we've got locums that we've had to use through COVID. We've got docs who travel internationally and provide care internationally. So, you know, there's no one model. It is certainly difficult, and you have to be really savvy to navigate the complexity of healthcare. And we have made it more complicated than it needs to be. But it is absolutely still possible.
Thank you.
I think there's a question in the chat from Nisha. What policies would you like to see implemented in Bayview or in hospitals in general that you have not seen widely?
So one, I would love to see healthcare workers protected. You know, and it's a fine line, right? So from healthcare workers are experiencing a lot of violence. And it's not really staff on staff, although it can be, right? That's kind of been a longstanding human resources issue that any organization has faced. whenever you have interpersonal conflict, it escalates to that point. But a lot of the patients coming out of COVID are more violent. They do not have as much patience. We're seeing more behavioral health issues. And so we have a lot of harm that's being done to patients. Now, there is a fine line whether or not the patients have kind of the mental faculty to distinguish between right and wrong in those instances. But nevertheless, it would be nice to have some laws that protect our patients more. I think for Bayview specifically, I know it's somewhat controversial, but so our uninsured patients who are unable to access insurance because of immigration status, there was legislation that was being proposed last year for them to be able to purchase insurance on the exchange, on the Maryland Insurance Exchange. That would be really beneficial to us, just because, again, we write off so much care. I would very much like to see, there's a lot of advocacy. We don't talk about it a lot, but around malpractice and the cost of malpractice. And it's just because of the statutes within the state of Maryland and, kind of tort reform. And so there are a lot of that we spend a lot of time protecting ourselves from lawsuits from patients, when I think we should be spending more time just taking care of our patients. Those are just a few of them. I do think legislation around hospital at home would be really helpful as well. And I think I saw another question pop up in the chat. I feel like a lot of healthcare providers feel bogged down by the administrative aspects of healthcare. What conflicts have you run into regarding this? And what are your opinions on the insurance sector and imbalancing? So, yes, providers feel very bogged down by administrative issues. And I think that's where I see my job, right? This is the job of administration. Our job is to be downfield blockers for all of you, right? Like, it is to remove those barriers, to listen to your pain points, to say, how do we ease the friction in the system so that we can work optimally? We are a system of systems. And so if you're in the OR and you don't have clean and sterile instruments, and you don't have the supplies that you need, and the bed's not ready when you need it, and the patient doesn't arrive right, it's a system of systems. We're all interdependent. And so I see all of that as operations and administration. And HR, you need the people that you need there on your team to take care of the patients. And we also need the money to pay everybody. So there's a lot that's wrapped up in administration. I like to be as transparent as possible, but also not to the point where it overshadows the clinical priorities and our focus on clinical excellence. What was part 2 of the question? What conflicts have you run into regarding this, and what are your opinions on the insurance sector? Yeah, so the conflicts are just that, right? I think it's when things don't operate optimally, right? We talk a lot about well-being, and we talk a lot about burnout, and I see the administrative burden of working in an environment that doesn't function optimally as being part of that damage to your well-being, right? So I take it very personally when things don't work well, because I know that it impacts culture, and it impacts people, and it ultimately impacts what we're able to do for our patients. Insurance is very complicated. We have, we could do a whole course on revenue cycle. I think our relationships with insurers in Maryland is unique. In that, on the inpatient side, we have global budgets, and we're an all-payer state. So regardless of whether you have Aetna or Care First or EHP, what your insurance company will be charged to come in as an inpatient to Bayview is all the same. On the outpatient side, on the clinic side, it's very different. But the state of Maryland is the only state that has this global budget, and we have this all-payer model that makes it very unique. So we have a different relationship with insurers we're trying really, really hard to push on value-based care models that have dual-sided risk. So and when I say that, I mean risk for the insurer who is paying us for your care, and risk on us to make sure that we are providing the highest quality and safest care, and that you are having the best possible outcome. So it is complicated. I don't work in the insurance world much, other than to say we pay very close attention to making sure that our bills are being paid, our denials are down, that people are appropriately being admitted to the hospital. And there are a lot of regs around insurance. So it is, thank goodness for the revenue cycle folks who love to do that work every day.
Can I ask a quick question? You mentioned a couple of times, I mean, it's interesting, the revenue side and sort of the sharing of the risk on both sides for you and the insurance providers. And then you also talked about sort of some of the, Apple Health and Google Watches and healthcare at home. Like, is there a path there that you see from a financial perspective to be able to kind of really put some muscle behind that idea, or is it more just sort of theoretical at this point?
No, there really is. I mean, so it's outside of the state of Maryland, I think a lot of the other health systems have really started to figure this out. The reason that hospital at home has not taken off in the state of Maryland is because we are in this waivered condition and we have this global budget. So in other states, right, they can very easily increase or decrease what they receive annually in terms of revenue, just based on volume, right? I have a fixed $900 million revenue stream that comes in, and whatever I do above or below that, that's all I have for the year. And so to invest in hospital at home requires a new revenue stream that doesn't exist today. And we can't negotiate with the payers because of this wonky relationship we have with CMS. And I'm trying to be overly simplistic on a very complicated issue, but so essentially the hospitals would have to say, we will fund it ourselves, and we will take volume away from ourselves on the inpatient side to be able to take care of patients at home. But I will tell you, I'm at the point where I'm ready to do it, because I have so many patients coming into the emergency department with chronic illness that could be better managed at home, that I just, a patient with cellulitis, we can send them home, and a couple of days of therapy, they do not need to be admitted necessarily. And so it's a financial incentive. It's not the clinical will is there. It's just within the state of Maryland, we haven't figured out the finances. There's no new revenue to support it.
Yeah.
I think in the other states, they've been able to negotiate that with payers, though.
Yeah.
I had a quick question. I just wanted to thank you for, being so passionate in this field and being like amazing at what you do. I think it's really reassuring seeing like on the administrative and the financial aspect of it, like seeing that kind of passion, which is like reassuring from someone going into kind of like the medicine side of it. And I also just wanted to ask you, like, you have a tough job. Have you in your field, in your career, have you gone into kind of like ethical problems that you faced, and like how did you kind of deal with it, and like what would you kind of recommend for us when we face our own ethical issues that come in with medicine, especially you on the financial aspect of it?
Yeah, it's really difficult, especially when you are resource constrained, which we have been. And I think that so interestingly enough, we had during COVID obviously experienced this a lot. And it's right. So there are big ethical decisions, and then there are, every ethical decision is a big ethical decision. Let me take that back. But we had kind of scarce resource committees of people who were multidisciplinary teams that had various right, interests represented, whether they were clinical or financial or regulatory or legal or patient focused, right? And we would really debate how we were going to approach the utilization of some of these scarce resources. And we still experience it today. I mean, most recently it was, with some of the MRI dyes, or it was, I think last year it was chemotherapy drugs, or when you think about formulas for babies, right? Now, thankfully, we have really great supply chain folks that make sure that we have these, what we need. But there are scarce resources, and you do have to, I think, use a team-based approach to make those decisions. I think that's probably, in terms of ethical decision, because I don't make clinical decisions. So maybe Dr. Ellis has a different perspective on that, but mine is really more around kind of resources and what we can and can't afford to do. I mean, I have to make hard decisions. I don't know if they're ethical necessarily, but around what I can and cannot fund. And sometimes I know that means that patients won't be able to access a program anymore because I have to discontinue that service. But thankfully, we are in a much better financial state now, and I haven't had to make one of those decisions in a while.
I would just jump in and say, you have to just make a decision. You know what I mean? Like, the reality of it is you'd like to be able to say that you can do both or finagle it, right? And oftentimes people in our situation, you try and do your best to finagle it and find that path, but ultimately you have to make a decision. And part of this work is learning to deal with those decisions and try and make better decisions as you go, Another saying we have in medicine is never go down on a sinking ship by yourself. So as the complexity increases, you bring people with different expertises into the conversation.
Yeah, just to continue that thought, I think that's what I see now in kind of the presidency role is one of the biggest challenges of the job is that decision making, is having to make those really difficult, complex choices, to be the leader in the room that everyone turns to for that ultimate yes or no. And it is a heavy, heavy responsibility. And it's one I think I take very seriously. And I also know that in making those decisions, you have to weigh your thoughts and your words carefully and really do your best to kind of bridge folks from kind of where the group is thinking about the issue to where you are, and really taking the time to talk them through the decision. And if you can't do that, I don't think you can't really defend your decision. You're not ready to make one yet. So, it is one of the toughest parts of the job.
Okay, as we are approaching 8:30, I think we're going to start wrapping up. Thank you, Ms. Nicholas, for taking the time out of your day this evening to come and speak to us. I learned a lot about the different paths we could go on to enter the field of medicine, and I'm also very inspired by how you were able to reach this point in your career, despite starting off not exactly knowing that you wanted to have this job as a president of a hospital. Yeah, so thank you to both of our speakers, actually, Dr. Ellis and Ms. Nicholas, for coming. Now we're going to go on to have some of the announcements for our club members. So you guys can feel free to leave. But again, thank you so much. And yeah, all of our members truly appreciate it.
Great. Thanks, everybody.